So thank you all for coming along to tonight's Transplant Talk Live, the Bone Marrow Transplant Foundation's webinar series. These webinars are an opportunity for us to delve deeper into a number of BMT, stem cell and CAR-T related topics, with tonight's webinar focusing on haploidentical transplants. For those of you who don't know me, I am Angela. I am the Patient Liaison Officer at Arrow, and I am coming to you tonight from the traditional lands of the Wadawurrung people in the Geelong region of Victoria. I have with me tonight our wonderful host, Yvonne Panic-Hudson. Yvonne is a clinical nurse practitioner in haematology at both the Peter MacCallum Cancer Centre and the Royal Melbourne Hospital, and she's also the co-host of the fabulous and very informative podcast, The Straight and Marrow. Yvonne is also one of the directors of the Arrow board, and she's coming to us tonight from the traditional lands of the Wurundjeri people in Naarm, Melbourne. Along with Yvonne tonight, we are very fortunate to have our guest panellists, Associate Professor John Moore from St Vincents Hospital in Sydney. He is an accomplished haematologist, and he is joining us tonight from the traditional lands of the Gadigal people in Sydney. And I will also mention John is also one of the directors on the Arrow board. I'll shortly hand over to Yvonne. She will be facilitating our Q&A session at the conclusion of John's presentation. So please feel free to pop any questions in that section. You can also pop them in the chat. We'll continue to monitor this throughout the session. We will endeavour to try and answer all the questions as best as we possibly can, but please do keep in mind that we're unable to answer any questions specific to your own health needs. And we do ask, if something does arise for you throughout this webinar that you would like to discuss further, we do ask you to please consult your treating healthcare teams. So without any further ado, I will hand over to Yvonne.
Thanks, Ange, and it's an absolute pleasure to host tonight's webinar. I've had the pleasure of knowing John throughout both of our very long careers, and more recently have had the pleasure of spending more time with him as we're both board directors at Arrow. He's really highly admired and respected in our BMT community, and really loved by patients. You know, gets amazing feedback from patients all the time. So hope you take that on board, John. It's a wonderful feedback to have. Haploidentical transplants are pretty complicated. I mean, even the word itself can, you know, really lead you to scratch your head. So John is here tonight to help demystify for you what a haploidentical transplant is, and what it means for the patients and families undergoing this version of an allogeneic bone marrow transplant. Please feel free to pop any questions in the chat. We will be opening those up at the end of John's presentation. So without further ado, I'd like to welcome John to share his presentation and share his knowledge with all of you. Thank you.
Okay, I'll just get my slides up. I'm hoping you can see those. Okay.
That's perfect.
Okay, all right. Okay, thanks, Yvonne. So I'd like to thank Arrow for inviting me tonight. I'm very excited to talk to everyone about haploidentical transplant. And I hope that I can sort of shed light on, as Yvonne says, is sort of a complex idea of doing transplants that are half matched, but I'm hoping we can demystify it a bit for you tonight. So this is a graphic that I've done for to try and explain to patients about stem cell transplant. So this is just talking about any donor transplant. So let's start from the beginning. A patient who may have leukemia, for instance, will come into hospital for about 3 to 4 weeks, and they will have conditioning, which might be chemotherapy, radiotherapy, or combination of both. often for about a week, and the timeline is in green down the bottom. The donor, meanwhile, will be getting GCSF injections, which stimulate the stem cells that grow all the blood cells and all the immune cells. And that is over a 4 to 5 day period, and then they go onto this machine which collects the stem cells. Those stem cells are then taken and given straight to a patient, usually just like a blood transfusion, once the chemotherapy and the radiotherapy are finished. And we call this day 0, which is the day the stem cells are infused. But it takes about 2 weeks for stem cells to grow into platelets, red cells, and white cells. And during that time, we need transfusions and antibiotics and drugs, usually to suppress the immune system. Because when a blood cells grow from a stem cell, they also grow T cells. T cells are cells of the immune system, which then attack the patient, and that's called acute graft versus host disease. And that sort of immune attack of the donor's cells against the patient tends to affect 3 organs: the liver, the bowel, and the skin. And so when patients leave hospital, we usually give them, like most hospitals would, give them a list of all their tablets. And those tablets are really to stop infection and to stop graft versus host disease. And that's usually 6 tablets or so. And there are 2 viruses that cause a lot of problems in that period once they leave hospital, and that's CMV and EBV, which are down there on the line between day 14 and day 100. And that sort of first 100 days is critical to a transplant for those of you who have had a transplant or work in the transplant area. Patients can get a graft versus host disease or get viral infections. They can get other infections. Once a patient gets to day 100, however, they usually feel a lot better, a lot stronger. Their immune system's beginning to recover. And then we try and see them less frequently and get them out and about a little bit more. And how long it takes us to get them off their tablets is very much dependent on chronic graft versus host disease, which attacks different organs of the body: the eyes causing inflammation, mouth ulcers, skin changes, often like eczema, and liver function abnormalities. There is a silver lining to this chronic graft versus host disease, which is where the donor's immune system will kill off any leukemia, lymphoma, or other blood condition that is left over. And that's really the big benefit of a transplant, is that immune effect. So let's talk about the donors. So everyone always asks, who are my donors? Where am I going to get my donors from? And the language is a little bit complicated, but the first thing to notice is that autologous means the patient's own stem cells. Allogeneic often means any other donor stem cells, but it can mean a brother or a sister or a sibling transplant. Syngeneic is not done that often, but that is an identical twin transplant. Matched unrelated donor in Australia means a donor from the registries, and there are 40 million people who can donate stem cells. Haploidentical, which is the topic of this talk, is a half match. So I'll talk to you about why it's a half match. And then cord stem cells are from the baby's placenta. Not done that commonly now, usually reserved for children, but still can be done. And where do we get these stem cells from? You can see in the top graphic, this is us in the theatre actually taking the bone marrow from the back of the hips in a general anaesthetic in theatres. This is really not done that much now. More than 95% of transplants done with patients' own bone marrow or in donors are collected from this machine here. And this is Amanda, one of our clinical nurse consultants with a patient there. And those machines work on a centrifuge that collects the stem cells from the blood. And they're the same stem cells that are in the bone marrow, but we're taking them from the blood. That is much easier for the patient and much easier for the staff, because we don't have to get dressed up and go to theatres and collect bone marrow. And we match people by something called HLA. So a lot of people say, oh, my blood group is different from my brother or sister. It's not done on blood group. blood grouping is not as important as this thing called human leukocyte antigen, or HLA. These are proteins on the surface of our blood cells which distinguish us from each other, but we inherit from our parents. And this inheritance is done through this chromosome 6 during this series of genes that sit on chromosomes. Chromosomes are the sticks that the genes sit on. And we often try and match for 4 or 5 of these genes, but they're on each chromosome, so there's 10 in total. So as a simplified version, this is a family where mother and father are not related, and they have 4 children, and each parent gives half their DNA to the children, and you can see that none of the children actually match. Okay, there's a 30% chance, just by chance, that those children will match, and that's the first thing we usually do is look at family to see if they're matching. If we can't find family, we look at other options. Now, if you look at activity in stem cell transplantation in Australia and New Zealand over the last 30 years, you can see that things have rapidly increased. And that really reflects similar activity around the world, that we're doing a lot more stem cell transplants. And we mainly do them for leukemias. And the green line shows that we mainly use unrelated donors. So this green line reflects matched unrelated donors. So if we don't have a donor in a family, we look for an unrelated donor. And there are 40 million people in the world who are usually blood donors who will donate bone marrow if required. So there's no bank of 40 million cells. It's just if they are required to donate, they are called upon. These are generally young people under the age of 35. And a fact that is important, I suppose, about the human effect of unrelated donors is that this all started with a woman called Shirley Nolan, who's in this photo, who is an Australian woman who lived in the UK, and her son had a very rare bone marrow congenital condition, and she fought very hard to try and find a donor for him for a stem cell transplant in the 70s and 80s. Unfortunately, her son died, but her legacy was that the bone marrow registry in the UK is called the Anthony Nolan Registry. But what's the chance of finding a donor? It's unfortunately very much dependent on your heritage, where your parents were born, and whether they're white, European, or Caucasian. And you can see that if you have a European background, usually a Caucasian European background, you've got a very high chance of finding a donor. But if you are, say, of African descent, then your chance of finding a donor is only 20% in the blue here, or less than 20%. And that's because registries evolved predominantly in the Western world, and so registries do not reflect particularly a community like Australia, where we've got a very different ethnicities in a multicultural society. So we have people from all over the world in Australia, which we welcome, and is a result of immigration. And you can see, if you look at the registries down here, in 1987 were quite small. As they got bigger mainly with white European donors, but not so much with people from other backgrounds. So that is where we can get the donors from the unrelated registry. But what about, could we get them from family? And this is where haploidentical comes in. And you can see this curve from the Australian registry shows that since about 2013 or 14, the number of half match or family members has gone up by about 3 or 4 times in Australia. And these are family members, a child to a parent to a child, or a sibling to a sibling that are not matched. So let's go back to our family where no one has a match. But here, AD can donate to AC because they share that blue bar. Alternatively, BD can donate to BC because they share that red bar. Or AC can donate to their mother, AB. So here you can see that within a family, we can find donors pretty quickly, but they're half matched. So why would we do that? Because then we can find donors in the vast proportion of patients. If you have a family member, it is a good chance that they'll be half matched, and therefore we can use them as a donor. It's very quick. It means that we can place donors and patients on a list, a waiting list very quickly. It's like having a brother or sister. We can move them around the list. It makes it much easier to plan. And of course, family are really willing to donate to help their loved ones. And we do it because we can use a drug called cyclophosphamide after the transplant, and that's really cheap. So that works really well, and I'll explain a little bit more about that. And we know particularly for blood cancers that predominantly occur in people in their 50s, 60s, 70s. And so children are good donors because the younger the donor, the better. And also we can use those cells for other things later on to give more stem cells later if we need them. But the question everyone would be asking is, but aren't they half matched? Why would we do that? Wouldn't that cause lots of problems? And the problem that it causes is graft versus host disease. So how do we overcome that? So graft versus host disease is when the donor's immune system attacks the patient. And it's been known for a long time, for instance, in these poor mice who got graft versus host disease in experiments, that it causes lots of problems. In the acute setting, it can occur in the liver, the skin, or the bowel. And in the chronic setting, it's a bit like having an autoimmune condition. You get eczema, mouth ulcers, skin rashes, eye problems. And this is when the donor's immune cells attack the patient, and it's usually because they're not properly matched or the immunosuppression doesn't work as well. So this all changed in 2010 when a group in the US tried to give a dose of a chemotherapy drug called cyclophosphamide 3 days after the stem cells. And to their surprise, what it showed in animal models and in patients was that it killed those cells that were attacking the patient, but didn't kill the cells that were killing off the leukemia. So this is the best of both worlds. And this started with this regimen called the Baltimore regimen, which was published in 2010. And I'll go through the details of this, but essentially this first week was suppressing the immune system of the patient, giving them 1 dose of radiotherapy, giving bone marrow in the initial studies, and then giving this cyclophosphamide day 3 and day 4 after the stem cell transplant. So how does that work? Cyclophosphamide is a chemotherapy drug that's been around since the 60s. Its big advantage is that it kills immune cells, but it doesn't kill the stem cell. So that's the big thing. People will say, oh, well, if you're going to give chemo after the stem cells have been infused, you're going to kill my donor's stem cells. But in fact, that doesn't happen. What it does do, however, is increase the time till the donor's stem cells grow from about day 14 to about day 18. And importantly, haploidentical has now been shown in multiple studies to be just as good as having an unrelated stem cell transplant or a sibling transplant. And it has been shown in adults to be better than cord stem cell transplant in terms of outcomes. And as I said, it's a cheap drug. It's not like we're inventing a new fancy drug that's going to cost the government a lot of money. So the details of these studies probably not you need to know a huge amount, but essentially the European Bone Marrow Transplant Group, which is the European Association of Transplant Units, has shown in their data that stem cell transplants for ALL using an unrelated donor, a mismatched unrelated donor or a haploidentical donor are all the same outcomes. Similarly, a trial that was predominantly done in Spain showed that if you took patients and they didn't have a sibling donor, they didn't have an unrelated donor, if you told them and flipped a coin, some of you will get a cord stem cell transplant, which we used to use very commonly up until about 10, 15 years ago, or a haplo donor, a family member who's half matched. The black lines show that more people were likely to be cured from their leukemias if they had the haploidentical transplant. So in adults, that is definitely a better option. And one of the reasons there is that cord stem cells are much more risky because the dose of stem cell is quite low and it's done on a per kilo basis. The Americans did a study as well, a flip of the coin study. You could get a haploidentical transplant or a cord transplant, and the people who had a haplo transplant did better, mainly because it was less complicated. There were less deaths from complications from graft versus host and those sort of things using a family member. So in adults, it seems pretty clear that if you had a choice between a family member as a haplo transplant or a cord transplant, you would use that haplo. But not everyone has a family member. So for people listening, it's possible that family members, for instance, might be too old or they might be unwell and can't be donors. So then a cord transplant is certainly an option that can be considered. And similarly, the American group showed in this paper that unrelated donors and matched unrelated donors and haploidentical have the same outcomes as well. And then finally, the French have actually done a randomized study where they compared haploidentical transplants to unrelated donors, but using ATG, which is an antibody against T cells. And this hasn't been published yet, but was presented at the European meeting last year. And again, the outcomes are the same. So that the message here is there is no downside to having a haploidentical transplant. People often feel like they're getting a stem cell source that might not be as good, but in fact, that's not the case. Now, in Australia and New Zealand, we have been doing studies in this area. And importantly, what we've tried to do is do these studies prospectively. It's not a flip of a coin study, but it's trying to look and see how we can do haploidentical transplants more efficiently, better, so we get better outcomes for patients. And so the first study we completed in 2020 and published in 2023. And in this study, we had 5 centres over 5 years, anyone between age 16 to 70 who didn't have a brother or sister or unrelated donor. And importantly, compared to that Baltimore study that I showed you, we didn't do bone marrow, we used it from the peripheral blood. And that was one of the issues that people were concerned that might cause more graft versus host disease. But that in turn, it actually turned out not to be the case. And many of you will know that there's 2 ways to give conditioning, one with less chemotherapy and one with more. And that often depends a lot on the disease you've got, how old you are, whether you've got other, what we call comorbidities, whether you've got diabetes, heart disease, all those sort of things. Generally, RIC or reduced intensity is done for people who are older with other illnesses. Myeloablative is done for people who are younger, have a leukemia that we think is quite aggressive, that we need to make sure that we kill off all that leukemia with the chemotherapy before the transplant. So in this one, we tried to mirror what that Baltimore study was, but we used blood stem cells instead of bone marrow. And with the myeloablative, we used a drug called busulfan, which had been used in other leukemias in the past for the conditioning or the chemo before the stem cells are given back. So what's the first lesson? There are several lessons that I'm going to go through that we have learned about stem cell transplant with haploidentical donors. And the first one is that engraftment is longer than if you were to have a matched donor, and that's because of that post-transplant cyclophosphamide. And it's on average 18 days before those white cells come back and 28 days before the platelets or the blood clotting cells will grow. The other thing that we've learned is that viruses are a big problem. And these viruses can cause a condition called hemorrhagic cystitis. There's a virus called BK, which we all have in our urine, in our bladder, and that when we have no immune system, that can start dividing again and cause inflammation in the bladder. And you can see that 30% of people who had the myeloablative transplant actually had this hemorrhagic cystitis. This can be quite mild, where they just have a little bit of stinging when they pass their urine, or it can be quite severe where we have to put a catheter in. So thankfully, most of them were not severe. The other thing that we noticed was that veno-occlusive disease, which is a chemical damage to the liver from the chemotherapy, was a little bit more common in the myeloablative, occurred in about 10% of people, and that can be a problem. But what we showed, and was one of the reasons we got this in a very good medical journal, was that the safety of the transplant was very good compared to world standards. So transplant-related mortality means that people dying from complications. And for those in the audience, there may have been discussions with your transplant physicians about the possibility of dying from complications. And that's why not everyone has a stem cell transplant. It's a risky procedure. But what we were able to show was that these complication rates were quite low by world standards, which was very encouraging. But still people had relapse. But what we did show was with the myeloablative, the relapse rate was quite low at 10%, which is often we would say to patients it can be as high as 20%. So that's good, that's encouraging, but there's always things that we can do better. We obviously want to do better over time. And the fourth lesson we learned was that we can get patients off their tablets really quickly when we use this post-transplant cyclophosphamide. And what we worked out was that if people didn't have graft versus host by day 60 after the transplant, we could try and get rid of their cyclosporin or the tacrolimus. And we could do that if you didn't have graft versus host. There was an 82% chance that you were going to be off your tablets by 12 months. And most of them, the average of getting off your tablets was 142 days. In the past, when we just used to use cyclosporin or methotrexate, that was never possible. So this is a major benefit to patients. They don't have to keep taking those tablets as much, but it gives their donors immune system a chance to grow, which hopefully kills off the leukemia. And that's got a basis in a study that was done by the Americans, published a couple of years ago in haploidentical transplant, where they showed, again, it was better than the standard treatments, but they showed that by day 60, the immune system is starting to recover. And if you haven't got graft versus host by then, you can often get off these tablets. And I often say to our country patients, we ask you to stay in Sydney for 100 days, but if you're good at day 60 or 70, we often let you go, but that's an unspoken rule. And finally, overall survival and disease-free survival, meaning you haven't relapsed, was really very, very good. So 72 to 74% of people were alive at 2 years. So this, for these reasons, this got into a very good medical journal, and I think it was because people overseas realised that we had a very high standard of care, which is really a real credit to the nursing in particular and allied health staff of hospitals around Australia, where the standard is high and is as good, if not better, than anywhere in the world. So what did we learn from these lessons? How could we maybe get a solution to what we were doing? So if the engraftment's a bit longer, could we increase the CD34 dose of the stem cells? Could we reduce the cyclophosphamide. They were things that we thought about doing, but they're quite big questions and require a much bigger study. So we decided to hold off on that. Similarly, with the viral infections, probably the best way is to reduce that cyclophosphamide dose, but we didn't feel that, again, we had enough patients in Australia to do that sort of study. But the veno-occlusive disease, that condition where the liver gets swollen because of the chemotherapy, we could do something about, and we switched the busulfan to a new drug called treosulfan, which is not really available that much in Australia. And secondly, could we increase the dose of radiotherapy from 1 to 2 doses and do it safely? And would that stop patients from relapsing? And this treosulfan has been compared to busulfan in the European studies and is better, but the cost is quite high, and so that is why we have done a deal to get it cheaper and to do it in a new study. And that's our second study, which we're currently accruing patients to. And what this study is doing is looking at that increasing the dose of the TBI to 2 doses, using this treosulfan instead of busulfan, and looking also at quality of life and economic outcomes. And so here you can see in the blue, we're giving 2 doses of radiotherapy instead of 1, and treosulfan instead of busulfan, and same with the MAC, treosulfan instead of busulfan, and also looking at using the biggest dose of radiotherapy you can give of total body irradiation is 6 doses. And so we're looking at that as well, and that's predominantly used for acute lymphoblastic leukemia. I'm happy to say that we have now, it's actually close to 50 patients we have accrued in this study, and we hope to get about 150 patients. And we now have quite a lot of centres involved, so I suspect we will finish this study about the middle of next year. And it's been a good example of collaboration between centres in Australia, trying to get better outcomes for patients. So the conclusions are that haploidentical transplant is a valid option for most patients who have family members. And those transplants, if you have a haploidentical transplant, the results are the same as whether you have a sibling or an unrelated transplant. And that's really opened up opportunities for people who would not normally have had a donor. You remember, amongst those 40 million people, a lot of people with Southeast Asian background, African background, do not have donors in those registries. So we have to find ways to help those patients, and this is a very valid way to do that. And in fact, in studies that we did in that first study, out of the 78 patients, something like 30 to 40 of those patients were not of Caucasian background, pretty much reflecting Australian society anyway. And this post-transplant cyclophosphamide is cheap and very effective at reducing graft versus host, despite patients not being fully matched. And we've got to look at ways of reducing infections and other problems associated with the transplant, which we're trying to do in our second study. So that's the end of my talk. I might just stop sharing, Yvonne, and then we can have some questions.
Thanks, John. I'm just having, oh, there we go. Had a little problem turning my video back on. Thanks, that was absolutely fantastic. And look, I'll invite the audience to pop your questions in the chat or the Q&A. Look, to begin with, I mean, I've got a couple of questions to get things going. You mentioned you had that great diagram up at the beginning where you talked about, you know, collection of donors, and you mentioned that obviously there's a, you know, wider pool of donors available for patients using haploidentical transplants. Is the preparation of donors any different in haploidentical transplants than for traditional transplants?
So no, so the patients still have to have a medical and see someone, have their bloods a chest X-ray to make sure they're fit to donate. Then in terms of the donation is still the GCSF injections, which they take at home and then go onto the machine. So a lot of units around the world are still doing bone marrow, mainly because the early studies looked at bone marrow, but we haven't found that that's necessarily a benefit in any way, and certainly logistically is very hard to do in Australian hospitals now with theatre time. And so, and it's much nicer for the donor not to have a general anaesthetic. So for the donor, the process is the same. The issue with family members being donors is that generally the same principles apply. The younger the donor, the better. So children donating for parents is relatively common. Parents donating for children is not that common in the adult setting, but does happen in the pediatric setting.
Yeah, and is that because parents of children are generally younger and fitter?
Yeah. So I think that's the thing. And so, there's quite a lot of data coming out now showing the younger the stem cell you can get, the better. So
Yeah.
when we're choosing donors, we tend to go for younger donors, and the outcomes seem to be a bit better.
Great, thanks. I did have another question. You mentioned that patients recover well, and you mentioned supportive care and the great supportive care that nursing and allied health provide. Is there any difference between the supportive care required between a patient having a haploidentical transplant and a traditional transplant? What are the sorts of things we need to keep our eyes wide open to?
So I think on the ward during the transplant, there's a couple of things. There's one thing that we have a bit of a rule on our ward. The time between day 0, when the stem cells are given, and day 3, when the cyclophosphamide is given, there is nothing stopping graft versus host in those 3 days. And so patients can get a fever. And for people in the audience, that's because the immune system of the donor and the recipients are sort of attacking each other, and there's nothing suppressing that immune system. So we have a rule in our ward that the first fever, if that occurs, is antibiotics. The second fever is we usually consider that to be what's called CRS, cytokine release syndrome. And so I think our nursing and allied health staff are much more attuned to that now because we do a lot more haplos. So that is one thing. The other thing is that risk of viral infection later on, and the risk of bladder toxicity. So watching out for that in the ward with urinalyses and looking for bleeding in the urine. That's quite a different thing that we weren't necessarily looking for before. In terms of after they leave hospital, it's again viral infection, unfortunately. So the high rate of viral infection, because we've got rid of a lot of those T cells of the immune system, they just can't control viruses.
Thanks very much. So we've got a couple of questions in the chat. The first one is, when is an HLA match not able to be used aside from age? So when is, other than age, what are other criteria for not being able to use an HLA match donor?
You mean like a family member or an unrelated donor? Yeah.
Yeah.
So with family members, it may be that someone is not well enough, have other medical illnesses that they can't be used. Alternatively, or they might have had a medical and then been shown not to be fit enough. Some people have very poor veins and can't be collected on the machines. That's another reason. But they're probably the main reasons. With the unrelated donors, if they're not matched completely, that is a problem for us. And also the matching of CMV, which is the virus that is the most common virus after the stem cell transplant, is a problem in that we want people to be matched for that CMV virus. So if someone is a donor who is negative and the patient has had the virus, that's a problem because the donor doesn't give any immunity to that virus. So that's a problem. And then finally, weight is a bit of an issue. So unfortunately, stem cells are done on a per kilo basis. And so if you have a bigger donor is better. And so that is often why there are more male donors, because they're bigger and often they have better veins, as you would know, collecting stem cells in the past. Yeah.
Thank you. We've got a question from Mary. She's prefaced her question by, not sure if I've got this right. Does using cyclophosphamide versus ATG change or alter progress or outcomes?
So that's a really, really, really important question, right? So that is, so currently, so at St Vincent's, we actually use ATG still for our siblings and unrelated transplants. But that French study I showed that ATG and post-transplant cyclophosphamide, same outcomes. The retrospective studies in the registry show ATG and post-transplant cyclophosphamide, same outcomes. The Canadians have done a study, not randomized, but they added ATG to post-transplant cyclophosphamide to reduce graft versus host even further. And I don't think they're pursuing that, because I think probably, I don't know, I haven't seen the results, but they're certainly not going to a randomized study. So that would suggest to me that maybe there were more infections or something like that. So many people in the audience who are in hematology may know that last week David Curtis's study got published in New England Journal of Medicine, which is pretty amazing for Australia, and is a credit to him and the team that got that study up and running. And that showed that post-transplant cyclophosphamide plus cyclosporin is better than cyclosporin and methotrexate. So some would argue that everyone, whether you're matched or haplo, should get post-transplant cyclophosphamide. I suppose I think that's quite valid, and a lot of units are working towards that. It is a change in how a unit runs and how we do transplants, but it is definitely likely to happen over the next few years.
So there's a question which I'm going to reword slightly in the chat, asking whether people ever receive third bone marrow transplants, John.
Third is pretty unusual, I have to be honest. It's extremely rare. The issue with doing a third transplant is if the first and second have not worked, it's unfortunately likely that the third will not work. And so that's a difficult thing for families and patients to understand. But and also patients are usually not fit enough by that stage to get a third stem cell transplant. And so what you're relying on a stem cell transplant is this graft versus leukemia effect. And if the patient's leukemia, which is often leukemia, is not responding to that immune effect, a third transplant may not be able to get that effect anymore. So there are lots of other newer therapies such as CAR Ts, which are not very commonly used in AML, for instance, but certainly in ALL, and monoclonal antibodies. So there's certainly other things that can be tried. Third transplant would be extremely risky, and also the chance of working is probably not as high.
Yeah, thanks, John. And look, I would concur with that. And I think, what's really important to remember, as you mentioned, is that each transplant is not its own unique experience. There's the cumulative effect of each transplant, plus any treatment patients have had prior to their bone marrow transplants. And our motivation is to do as much benefit and little harm to our patients.
That's exactly right. Yep.
Yeah. So there are no further questions in the chat. John, have you got any closing words you'd like to share with us before I hand back over to Ange?
I suppose I would just say to patients and carers that are in the audience that this is haploidentical is one of many options for transplant, and it's worth discussing it with your transplant team individually about that. But I suppose the message from me is that the data shows that if the donor is the right donor, then the outcomes are very similar, and it's a very exciting time to be working in that area.
Thanks very much, John. And look, I agree with you about that. You know, it is a really exciting time to be in transplantation. Any new innovation in transplantation is potentially means great things for our patients. So yeah, I absolutely agree with you. So thanks again, John. It's been a wonderful conversation. Thank you to our audience, and I'll hand back over to Ange.
Thank you so much, John. That was just a fabulous presentation. It was so informative, and I'm sure our audience got a lot out of that as well. So to our audience, thank you so much for coming along. There will be a recording of this webinar that will come to you via a link in an email once it's been uploaded, so look out for that one. We do also have a short survey at the end of the webinar that we would love you to please fill out if you can. It takes a very short amount of time. It is completely anonymous, but it does help us to improve our webinars. It gives us the opportunity to look at new topics that you may or may like to hear about in the future. And it just helps us improve our overall service to you all. If you do have any questions arising from this, once again, for your own health, in your own health situation, please contact your treating healthcare teams. We are also here at Arrow to support you with other services. We have our support group. We do have some financial services available as well. So if you would like to, please reach out to us. You can find us at www.arrow.org.au. And of course, there'll be somebody there on our contacts page that will be able to help you with your inquiry. So please look out for any future webinars and podcasts that are coming your way. Our webpage is always updated. Once again, thanks so much, John, for attending. And we look forward to seeing you all again soon.